أيوة، مساء الخير يا دكتور أحمد، يا دكتور محمد ويا دكتور عبد الحميد. أهلا بيكم في الإبيسود نمبر 9 في الهب.
مساء الخير يا دكتور احمد.
مساء
مساء الخير يا
الخير.
دكتور احمد. مساء الخير يا دكتور مهدي، منورنا.
مساء الخير يا عبد الحميد.
اهلا بيك يا دكتور حسام.
يا أهلا يا أحمد. طيب، بسم الله الرحمن الرحيم. Today we are going to start the iHub session, episode number 9, with the title of Cataract Extraction in Glaucomatous Patients. Today we are joined by special panelists. Unfortunately, Dr. Alaa Elzawawi is not able to join us. I would like to thank Novartis for sponsoring this symposium, and I'd like to thank RM Events for helping us to organize the symposium. And finally, I want to thank the panelists for giving us enough time to work to this hub session. First, I will الشاشة.
هو ادخل من تحت، من عندك، من الباوربوينت.
أول باوربوينت قفل، ثانية واحدة.
افتحه تاني حضرتك. شغالة
شغالة كده.
خليها فول سكرين.
ما أنا لما باجي أقلب
لا، فول سكرين وبعدين اسكيب لما تحب تطلع منها.
لا، أنا لما باجي أقلب السلايد مش هقلبها كده، مش. We're going to talk first about pre-operative considerations. The most important question we are all faced with, as we all know, glaucoma and cataract usually occur in old age. Most of us are faced with this problem, patient having cataract and glaucoma. I want to hear the opinion of our panelists about their approach to these different cases. Let's start with Dr. Ahmed. Ahmed Shama.
Actually, I don't prefer nowadays the combined surgery. If the patient is having mild glaucoma and is controlled by one medication, I go for cataract only. If the patient is having glaucoma that is not controlled by one or two drugs, I will go for glaucoma first. So I usually don't combine the two procedures together nowadays.
Any type of cataract or the special cataracts?
If the patient is having pseudoexfoliation syndrome, I will go for cataract surgery. I will prefer cataract surgery earlier in such cases, and because it will help in the management of the glaucoma. And if the patient is having a narrow angle glaucoma, I will go for cataract surgery, and this will help in the treatment of glaucoma. But if the patient is having open angle glaucoma and he is controlled on one medication, I will go for cataract only, and I will advise him to continue on this one medication after surgery. If the intraocular pressure is not controlled after the surgery, we can do glaucoma surgery after that, and the prognosis is good. I don't find any problem in doing another glaucoma surgery after cataract extraction.
You don't prefer combined surgery?
The problem is the end of cataract surgery is that you want the eye pressurized, while in cases of combined phacotrap, you want the eye is leaky. And that's why I don't prefer nowadays to do combined surgeries. And I found that in my hands, doing single surgery is much better in my hands.
Okay. What about Professor Mohammed? Do you have different opinion?
Actually, if glaucoma cannot wait, but cataract can wait. If we have a patient with advanced glaucoma, I always prefer to go for combined surgery from the start, but with specific technique using the releasable and controllable sutures. If we have a patient with mild glaucoma, we can start with one or two medication. We can do, especially if the case is relatively narrow angle or pseudoexfoliation, because after cataract surgery, the patients can had an intraocular pressure lowering effect of cataract surgery of about 3 to 5 millimeter mercuries. In cases of moderate glaucomas, it depends. If he is on more than one medication, I always go to combined surgery. If he's on one medication, I do glaucoma first, then I will go for cataract later on.
Does Dr. Abdelhamid have any different opinion?
I would like to take the last words from Dr. Shama to start my opinion. He doesn't like to leave the eye in a leaky condition. This is very nice. That's why abandoning the penetrating trabeculectomy will help you to combine the surgeries. This is the first issue. Number two, I would find that management of a case of pseudophakic eye, complaining or attacking a case of pseudophakic eye for the issue of trabeculectomy is full of unsuccessful events, because cataract itself exerts some inflammation at the level of the function of the trabecular meshwork. Also, performing cataract surgery after trabeculectomy definitely would affect the procedure you have already performed. Reducing the decision to single surgeries or isolating the surgeries, other factors should be considered, especially the age, the cause of the cataract, and the cause of the glaucoma. And I agree that leaving any eye in a leaky position is not accepted. So we can consider combination, but in a semi-closed system, like the new techniques of doing angle surgery, whether ab externo, ab interno, or non-penetrating trabeculectomy, together with cataract surgery, even in mild cases of cataract, even in mild or advanced cases of glaucoma. Thank you.
I know Dr. Ahmed Shama is a mainly cataract refractive surgeon. I know doing phaco trap will leave the patient with few diopters of astigmatism. And I think doing combined surgery.
Not only that, Dr. Hossam, but also the visual rehabilitation of the patient is very bad in phaco trap, as well as the eye is sore and is not very happy after surgery. That's why I usually prefer to do, if I can do, only cataract. If the patient is controlled with one medication, I will go for cataract.
Sometimes we are faced with the patient +2 or +3 nuclear cataract, open angle, and advanced glaucoma. So I think, in my opinion, I'd go for refractive combined phaco trap, but I know that tell the patient that his vision will not improve until 6 weeks at least when we remove the conjunctival sutures. What about Dr. Mohammed? Do you agree with me, or
for advanced glaucoma, you mean?
I mean, patient with advanced glaucoma not controlled medically and +3 nuclear cataracts?
For sure, I will go for combined surgery from the start, but with controllable and releasable suture.
And with
because we have no much chances. If you did cataract and this patient developed any sort of spikes, you will lose his vision. If you do if you do trabeculectomy alone and you encountered with any complication, it will be difficult to solve. But doing both together, for me, it is the best option. I always do it.
Okay, we'll come to the next question. If you have a patient with mild to moderate glaucoma with insignificant cataract, when do you decide to go to cataract surgery in these patients? Dr. Abdelhamid, we'll start with you.
Sorry, can you repeat the question, Dr. Hossam? I'm sorry.
Patient with mild to moderate glaucoma and have insignificant cataract. When you decide, are there any situations you decide to remove this cataract early?
Of course, gonioscopy is standard before such a decision. Refraction is very important. Van Herrick assessment is very important. However, gonioscopy decision should be reliable, dependent upon gonioscopy. If his open angle, I can proceed just for glaucoma surgery, non-penetrating.
No, it's controlled glaucoma. I mean for cataract only.
If his narrow angle or occludable angle, lens surgery should be considered. Provided this is a condition of primary closure or primary open angle glaucoma, not secondary.
Dr. Ahmed Shama?
I advise my patients, if they have high refractive error, high plus and narrow anterior chamber, to do it earlier. If they have pseudoexfoliation syndrome also, I advise them to do it early. And I explain for them what's the benefit of doing early cataract extraction in such cases.
But do you do clear lens extraction or refractive lens extraction in glaucomatous patients?
In myopic patients, no. In hyperopic patients and with a shallow anterior chamber, yes.
Yes. Dr. Mohammed, do you have any other opinion?
I agree with Dr. Shama for what he said just right now. For patient with hyperopic condition, I prefer to do clear lens extraction because it will create space in the anterior chamber and it will help to improve the condition of the glaucoma in this case.
As I heard now from my panelists that you prefer early cataract surgery in pseudo-exfoliation and narrow angle and occludable angle. Is there another situation you prefer early cataract surgery in glaucomatous patients other than pseudo-exfoliation and narrow angle?
Microspherophakia.
Microspherophakia. Abdelhamid, I know what you're going to answer.
Definitely, we have conditions like nanophthalmus and posterior microphthalmus. These young patients are very much demanding as regards their refractive surgery, and astonishingly, it runs in an autosomal dominant condition, appears in families. You might find patients that have their elder brothers in the late 30s and early 40s. Surprisingly, you can find these patients have lost their vision because of the intractable glaucoma not responding to any medical treatment, and makes the anterior segment surgery in a risky condition because of the advanced chronic narrow angle status. That's why refractive lens surgery in such young, early age is beneficial, and we should encourage.
Dr. Mohammed, do you have any addition at this point?
No more.
Okay, last question in preoperative considerations. When I have patients on glaucoma therapy before doing cataract extraction, and I'm going to do phaco alone, do you change in the medical therapy of the glaucomatous patients before surgery, Dr. Mohammed?
Actually, if he is using pilocarpine or something like that, I have to stop it a little bit earlier than the cataract surgery, than the glaucoma surgery. And if he is on carbonic anhydrase inhibitor, I could try to minimize the use of carbonic anhydrase inhibitor a little bit before surgery. And for sure, we will start to prepare him with the anti-inflammatory drugs like non-steroidal anti-inflammatories and some steroids topically for surgery.
Dr. Abdelhamid, do you have any?
Traditionally, the prostaglandins are preferred to stop sometimes at least 2 weeks before surgery. However, practically speaking, I don't find any problem to continue any type of medication except if the patient has some sort of allergy. You should identify this allergy before the surgery. So traditionally, some recommend stopping the prostaglandins because of its effect on the inflammatory condition in the operative and post-operative condition. However, I don't find any problems as mentioned in the literature.
Ahmed?
Actually, I don't see more of my patients having pilocarpine nowadays. They don't find pilocarpines in the market.
It's not available in the market.
But as Dr. Mahdy said, we have to stop it like 7 days before surgery if they are taking still pilocarpine. Also, if the patient is taking carbonic anhydrase inhibitors, and I'm going to do combined surgery, keratoplasty and or DMEC, for example, the carbonic anhydrase inhibitors are incriminated of doing some harm to the endothelium. So we have to change this before surgery. As Dr. Abdelhamid said, in our practice, we didn't see a lot of patients having significant cystoid macular edema with the use of prostaglandin analogs, but I have only 1 or 2 cases that I remember having this problem of severe cystoid macular edema, and it became okay when we stopped the medication after surgery.
As regards this point, I've seen few cases of macular edema after uneventual phaco in patients using prostaglandins, but most of them were diabetics. So I insist to stop prostaglandins, especially in diabetic patients, because if you have macular edema, it's very difficult to treat. I have a patient now, I'm giving him injections for 4 years. Whenever I stop, the macular edema comes back again.
Yeah.
Now we're going to the next part of our discussion, which is operative consideration. We were going to discuss special consideration taken in doing cataract surgery in special situations. First situation, if I'm doing cataract surgery in a patient with a previous bleb. Dr. Mohammed, I think he has a video to show us.
Yeah, I think there are so many considerations in these patients. Actually, we have to avoid touching the area of the bleb and to be away a little bit. And if we have a patient with non-controlled glaucoma and we are going to do phaco, we could try to do some revision for this bleb as the case that I'm doing right now here. This patient is a case of neovascular glaucoma with failed bleb, and I'm going to do trap. After I finalized the implantation of the lens, I tried to revise to open the ostium internally using Helon, but this was not success. It didn't open as I want. That's why I resorted to do external revision later on after implanting the lens. Here, I will try to remove some of the sutures. Then I will use the irrigation cannula to push some fluid from the internal ostium under the flap. Here I'm just cutting the suture of the previous flap transconjunctivally. Then I will elevate, because here most of the occlusion was in the bed of the trap and not from the internal ostium or from the conjunctiva. And you will see later on here I'm elevating, after cutting, I'm just trying to elevate the flap here. As you could see here, now it's nearly free, the flap. Then I went through the, after I completed closure of the wound during IA of the viscoelastic, I went with the cannula here, as you could see, into the internal ostium, and you could see just sudden popping up of the fluid in this area, as you could see here right now. And this was the case.
Okay, thank you, Dr. Mohammed. I know, Abdelhamid, you have experience with internal or ab-internal revision of filtering bleb during cataract extraction. Would you like to give us an idea?
I do the ab-internal revision even without cataract surgery in pseudophakic patients, and I don't like to do it in phakic patients. So if you have a patient with recent failing trab within 4, maximum 6 weeks, you can do under viscoelastic with the spatula creation of the pathway, of the whole pathway from the inner to the under the scleral flap, cutting the stitches and retrieving the spatula under the conjunctiva. This can be a part of an internal revision together with injection of anti-VEGF or mild anti-metabolite like 5-fluorouracil. However, if the patient is has a failed bleb, I mean by failed bleb, at least if the time after the trabeculectomy was more than 6 weeks, I feel that this will not be of benefit.
Would Dr. Ahmed Shama, would you like to add something at this point?
I want to add that we don't have to touch the area of the bleb at all. We do cataract surgery away from the bleb. We have to do the 3 incisions away from the bleb because touching the bleb in any of the incisions can lead to failure of the bleb.
Okay, I would like to ask Dr. Ahmed, what are the precautions and difficulties do you face when you're doing cataract extraction in a pseudophakic glaucomatous patient?
Doing what?
Phacoemulsification in pseudo-exfoliation glaucomatous patients. Patients with pseudo-exfoliation.
First of all, I have to know the following. The mydriasis of the patient will be difficult because in such cases, they don't dilate well, first. Second is the weak zonules. I have to be very aware during the capsulorhexis as well as during the aspiration irrigation and during the evacuation of the nucleus. I have to do wider capsulorhexis that then I'm used to do, and to do rotation of the nucleus with 2-point rotation of the nucleus and not one single point of rotation, because if you do a single point of rotation, you may endanger more the zonules. These are the main precautions that I take during cataract surgery in pseudoexfoliation syndrome. I'm now doing removal of the pseudoexfoliation material in front of the anterior capsule in most of these cases. I don't know whether this is beneficial or not, but you can remove all this material from the anterior capsule at the conclusion of the surgery.
Do you use any special viscoelastic in pseudoexfoliation?
Actually not. I'm using methylcellulose in all my cases of cataract surgery. I don't use sodium hyaluronate anymore.
Okay, I'd like to ask Dr. Abdelhamid about the precautions you take in doing cataract extraction in a patient with narrow angle.
Measuring the intraocular pressure before surgery is very important, and trying not to attack a patient with more than 30 or high 20s intraocular pressure. I would like to manage a case which is quiet, unless the patient is has been in an attack within a couple of the last couple of days. This is an urgent situation. I don't prefer to use extensive systemic tension lowering measures in the immediate preoperative days. Gonioscopy is very important to be performed not before surgery immediately, but with the best intraocular pressure I have reached preoperatively in order to assess the angle very well. I don't like the synechiolisis. I think it is an extra maneuver of no benefit that will lead to some sort of inflammatory reaction and iritis in the post-operative period. If the patient has more than 180 degrees occlusion, whether oppositional or synechial, I go for routine trabeculotomy under deep sclerectomy, and this gives me a very safe result with no low IOPs post-operative. Finally, I would insist on removing of the viscoelastic behind and in front of the IOL in a near 100% manner. Finally, if the patient in the post-operative period had still elevated intraocular pressure not satisfying my target pressure, I prefer to do ab-interno revision in the immediate post-operative period, and I can attack the patient within 2 weeks, converting the non-penetrating window to a penetrating window if I didn't reach within 2 weeks my target pressure.
I think Dr. Mohamed, you had something to show us about cataract extraction in narrow angle closure.
Yeah, luckily I have this case only yesterday. That's why I just finalized editing this case 15 minutes before this webinar. This is a case of acute on top of chronic angle closure glaucoma with cataract. The eye is very narrow and prominent superciliary. That's why I started do our old lateral consultomy just to find the room to do the trap. And then I did a traction suture. Then I started doing the trap in the usual way. After I created the trap and apply, here I'm just going in the usual way, doing conventional trap while the eye
Can you
is
make
still
it full screen, Dr. Mohamed?
Yeah, okay,
Full
just
screen.
1 minute. Yeah, okay. It is one. Okay, sorry. It will come now.
Yes.
Here I am always prefer to do the trabeculectomy or any scleral dissection while the eye is under high pressure, so I can create a good flap. This eye was a special eye for me. It was very narrow, and the surrounding superciliary ridge tension is very high. With that's why I did this lateral consultomy. Then I applied traction suture using the 8O vicryl through the limbal area. Then I am doing the trap. Then after creating the flap, I applied mitomycin. Then after I remove the mitomycin soaks and I wash the area, I will do a posterior scleral tap and I remove part of the vitreous using the 23 gauge vitrector, as you will see here. The idea I do want to open the eye under pressure. Now I'm doing inserting the trocar. Then I am cutting some of the vitreous using the mid-vitreal aspiration with the vitrector. Then I removed the trocar again. Then I got my mitomycin. Then I removed it. Then I will start doing phaco through the same incision of the trap as I always do. In this manner, I avoided doing rexes in a shallow anterior chamber. I avoided opening the anterior chamber while the eye pressure is high. I didn't have any troubles except the troubles of the narrow eye. Even while I was doing the rexes, it was very difficult. I couldn't have one plan for the eye. That's why I always did it. I did it with the insulin syringe, as you can see here, and it went well. And then I did the hydrodissection through multiple boards from both sides and through the superior wound. Then I did phaco, and if you are see here that you see that I didn't rotate the nucleus at all. I disassemble the nucleus while it is in situ. Utilizing the side movement of the machine without rotation. Now I created 4 quadrants, then I removed the quadrants, then without any rotation. I always rotate the last 1 or 2 quadrants while without exerting any pressure under the new. Then I washed out the remaining vitreous, the remaining cortex. Then I implanted the IOL after filling the eye with the plastic. After putting the lens in place, I used the Kelly's Divine Bunch to create the scleral cloak protection. Then I did peripherectomy. Then I did the suture and buried the suture inside. Then I securely closed the conjunctiva to the limbus, and I closed the remaining board of the conjunctiva using 8 or 10 vical sutures. Here I am finalizing closure of the conjunctiva. It was 2 wing sutures here. So the conjunctiva is very tightly opposed to the limbus. Then I'm closing now the conjunctival wound. So the eye completely closed and watertight.
Okay, thank you, Dr. Mohammed, for this nice video.
Thank you
I
very
would
much.
like to ask you, Abdelhamid, about you have an experience by doing cataract extraction in a patient with juvenile glaucoma after trauma, and you have a video to show us.
I'll show my video. This child has about 4 years, and as we can see, he's operated for trabeculectomy before, and he had a trauma. After the trauma, intraocular pressure increased again. Through a temporal incision, as we can see, I'm not used to temporal incision. I attack, and as we can see, there is a vitreous band going into the anterior chamber. We used triamcinolone in order to highlight it. Because of this subluxation induced by the trauma, we inserted a CTR. Then we implanted the IOL in the bag. Then we put enough carbachol in order to narrow the pupil. We were attacking this eye through a temporal incision because we wanted to do an internal approach goniotomy. This is the starting point and creating the window. And this is how we create a button or a knob in the Prolene suture in order to cannulate this Prolene inside the canal of Schlemm. And as we expected, the Prolene will not go 360 degrees because of the trabeculectomy. because of the previous trabeculectomy. However, as we can see, we used this cannulation in 2-clock manner on the right side and left side, and we pulled it in a way in order to do as much goniotomy as we can reach. We tamponated the anterior chamber with air, and we were satisfied with the post-operative result in a way that the patient in the second way had nothing related to the conjunctiva, so his post-operative period was very gentle.
دكتور حسام، دكتورة إيمان نبيل كانت بتسأل if in your experience the patients with pseudoexfoliation syndrome, do they really have a good effect on intraocular pressure control if they do the cataract?
Yes, theoretically, if you correct the pseudo-exfoliative materials that are blocking the angle will be less. Practically speaking, I have a patient, I've done her pseudo-exfoliation. She has an advanced glaucoma. She was unexpectedly 40 years old with advanced glaucoma on 3 drugs. After doing the pseudo-exfoliation, after doing the cataract in the pseudo-exfoliation, as I told you, I prefer to stop prostaglandins. After 1 or 2 and now 3 months post-operatively, I didn't need to use the prostaglandins. So practically and theoretically, cataract extraction alone in pseudo-exfoliation can help control glaucoma.
Yeah. Dr. Ahmed?
ايوه كنت عاوز اسال I would like to ask Dr. Ahmed Shama, what are the precautions you do in doing cataract extraction in an advanced glaucoma patient to avoid wipeouts that may occur?
First of all, I usually use the Centurion in such cases with active pressure control because I don't want the pressure during the surgery to become above 50. Usually I go to 45 to 50 millimeter of mercury, not more. I don't depend on the bottle height. I depend on the active part in the Centurion. I do a very slow decompression of these eyes before surgery, and I do decrease the intraocular pressure before surgery as much as I can. Also, usually I give these patients mannitol after cataract extraction, like 2 or 3 hours after the surgery to avoid increased intraocular pressure or spikes of intraocular pressure after the cataract surgery.
Okay. Dr. Mohammed, I think you have to show us a video about advanced cataract extraction in advanced glaucoma.
Yeah, but before this one, I have some comment in patient with pseudoexfoliation. Actually, in pseudoexfoliation, we had to differentiate between glaucoma associated with pseudoexfoliation and pseudoexfoliation glaucoma. Glaucoma associated with pseudoexfoliation, if we did proper cataract extraction and we wash the anterior chamber, and I think in this case the intraocular pressure is lower to the desired pressure. But in pseudoexfoliation glaucoma with advanced trabeculitis or something like this, and the trabecular meshwork is completely clogged with the exfoliation material, there is no way except to do surgery for glaucoma in this patient away from cataract or combined with cataract. For the cases with advanced glaucoma, the idea of Professor Ahmed is not to keep the eye leaky to avoid the wipe-out phenomenon, and to properly control the intraocular pressure without any spikes. I resorted to doing trabeculectomy with controllable and releasable sutures. As you could see here in this video, I'm doing trabeculectomy. I always do this traction suture. I will skip it a little bit. Then I dissect the conjunctiva. Then I do trabeculectomy in the usual way, as you see here. Then I apply mitomycin for all patients. Then after finalizing the mitomycin stage, I created the side board, the emergency board, as we could see. Then I did the trabeculectomy here. I remove a block dissection from the posterior part of the sclera, then iridotomy. Then later on, I am creating the controllable suture, which is actually the Bing Hao ones, is not mine, but I adopted this technique from him, so I can play with this suture later on. And I do 3 or 4 throws. Then I do it like this with a long loop. I do the same here. So this suture, with this suture, you can control the intraocular pressure post-operatively through the conjunctiva without any revision using a blunt-ended forceps. As you could see here, it is a looped. It is a looped sutures. Then after adjusting the tightening of the suture, when I found one which is little bit tight, I try to manipulate intraoperatively. Then I test for the pressure again. Then later on, now I will apply the releasable one that I play with it to keep the pressure a little bit high early post-operative. Here you see how much is the flow. Then I am doing the releasable one now, which is very important. So when I finished the phaco trap or the trap, I keep the eye with a pressure little bit higher than the desired one. Then 2 to 3 days, I will pull out this suture after the conjunctival flap is closed, so I didn't have any leakage from the conjunctiva, and avoid the early hypotony with the wipe out phenomenon that I always afraid of it, especially with advanced cases that we see right now. The idea of this releasable suture is the same as the controllable suture, but it has some of the arms here. You could pull it through the exposed part of through this bridge over the cornea. Here I'm adjusting the flow. I cut only this one, then I'm cutting here. So, and I leave this exposed part of the suture here. I close the conjunctiva. You could see here that the suture is very clearly seen through the conjunctiva. No hemorrhage, no excess subtenon tenon capsule. If you have excess tenon capsule, you will not be able to play with this suture later on. I always close with these 2 wing sutures. Then I close this conjunctival suture with the 8-0 vicryl or 10-0 vicryl. And now the case is finished.
Okay, thank you, Dr. Mohammed, for sharing this video. Now we are going to show 2 different techniques of combined surgery. Dr. Abdelhamid will show us his technique of phacoemulsification with trabeculotomy, and I'm going to show after that classical phacotrabeculotomy. Okay, Dr. Abdelhamid?
Okay, Dr. This is a case of 320-degree trabeculotomy using the Prolene suture. This is how we create the superficial flap, third of the scleral thickness with the 15-0 scalpel. Then we are going to prepare the deep flap, very deep to the level of the ciliary body and choroid until we reach the scleral spur. And as we can see, this is a case of chronic narrow angle glaucoma, where there is no seepage. At this stage, we start to perform our cataract. Cataract incisions are away from the glaucoma placement surgery, totally away. We finish our phaco, inject our IOL, and complete the surgery under viscoelastic. So we postpone removal of viscoelastic to the termination of surgery. This is the point of bleeding, which denotes the place of the canal of Schlemm, and we can cannulate the proline 320 degrees until it comes out from the other side. Then we are doing the trabeculotomy. However, we are not completing it in order to preserve the trabeculodescent membrane to keep the eye in a closed system and get the proline out. Then we did an internal fistulizing surgery, and this is as we can see, complicated by hyphema because of the 320-degree trabeculotomy, and this terminates my surgery with a closed system phaco-trabeculotomy.
Thank you, Abdelhamid, for sharing with us your experience in angle surgery.
I have a question for Dr. Abdelhamid, if you could allow me.
تفضل لي.
Dr. Ahmed?
اتفضل.
This is very nice surgery if the pathology was in the trabecular meshwork. If the occlusion is beyond the trabecular meshwork, do you think that it would work?
Look, we don't have any way to assess the post-canal of Schlemm channels.
Sure.
There is no way. But
yeah, I know.
When we find that trabecular meshwork is not working and we find no seepage, this will suggest a pre-trabecular closure.
Yeah.
That's why this condition, we call it a pre-trabecular closure, chronic narrow angle, and we expect that it's a single pathology, either pre-trabecular or trabecular and post-trabecular. The broad classification of glaucoma is narrow angle, pre-trabecular, and open angle trabecular and post-trabecular. Finding no seepage directs us to pre-trabecular closure. And if we yes,
which proline type are you using?
I use proline 5O.
5O.
5O proline or 6O proline, but this is 5O proline.
Yeah.
The main problem in such cases is to be 100% sure that you are in the canal of Schlemm.
Sure.
And this can be very easy after lowering the intraocular pressure by the phacoemulsification. You can find the blood easily regurgitating through the terminating point in front of the scleral spur, and you can identify it easily. And if this video was in a slow motion, you can track and trace the proline going along the limbus, and you can see it by itself. Sometimes actually I lose the proline, I didn't find it, but I don't have problem. I do the regular hard trabeculotomy and fulfill my surgery.
Actually, nice surgery for sure.
Thank you.
Okay, now I'm going to present classical phacotrabeculectomy. This case presented with uncontrolled open angle glaucoma, and as you see, there was a narrow pupil, clearly white cataract. I usually do my phaco in the upper temporal quadrant or the upper nasal, depending on the eye. After taking the traction sutures, I inject mitomycin with xylocaine. I open my conjunctiva. Wash the excess mitomycin when doing diathermy. I usually use
بتخفف الميتومايسين بالزيلوكين.
بحط mitomycin لو patient, if the patient is under sedation. If under general, I put mitomycin only. I do trapezoid flap, nearly half thickness. Then with Bart Barker knife, I do the dissection of the flap. When we go to the cataract part, some days you feel that you are lucky. This is one of the days. I was preparing myself how to dilate the pupil and to stain the white cataract. After injecting adrenaline, the pupil was widely dilated and surprise, marvelous red reflex. No need to stain and no need to dilate the pupil. Cataract surgery here, I do large capsulorhexis. After doing hydrodissection and rotation of the nucleus, I use the horizontal chop to divide the nucleus into two parts. Then removing the lower part of the nucleus. It was actually hard. Then after removing the epinucleus, there is IA, removing all of the cortex. Then injection of the IOL. And then going to the trabeculectomy part. I do the incision with the super blade, anterior part of the cornea. Then I remove the block with a punch, tennis punch. Then doing peripheral iridectomy. I close my scleral flap with two sutures at the edges of the trapezoid. I take them with 10-0. And it is very important to vary the sutures. If it does not vary easily, I do counter pressure on the scleral flap. Then I close the conjunctiva with horizontal matrix suture. As you see, I go from the cornea to the conch. And then go back from the conch to the cornea, and I tie the suture horizontally. After taking the two sutures, I repeat them, not to leave any edges, and then I do hydrodissection for the patient.
والحقيقه دكتور حسام I like the pre-placed sutures وانا اتعلمتها من حضرتك. البري بليز سوتشرز بتخليك سيف جدا وبتقفل بسرعه immediately بحيث انها تبقى موجوده. وبرده الهوريزونتال ماتريس سوتشرز دي مهمه جدا لان بتخلي في دايركشن للفلويد انه يروح ورا، بيبقى الجزء القداماني. فالحقيقه التو تيبس دول الحاجات المميزه جدا للترابيكيلكتومي بتاعت حضرتك. تسلم ايديك.
تسلم.
Very nice surgery, Dr. Ahmed Bashir.
Thank you. احمد شامة. هو احمد شامة معانا ولا؟
هو لسه معانا بس صورته مش معانا.
لا وضع
معانا.
انا مع حضرتك. very nice surgery حضرتك. سؤالي حضرتك في الاخر بتعمل انجكشن للانتيو تشامبر، بتملاها سلاين وبتشوف الاماونت اوف فلتريشن اخباره ايه والبلاب فورمد ولا لا، مش كده؟
ما انا بعمل I do injection of saline in two steps. First, after closing the scleral flap, I inject saline in the anterior chamber to see the seepage of aqueous from the scleral flap. And after closure of the conjunctiva, I inject saline here in combined just hydro injecting in the wound to close it produces aqueous, which shows us the tightness of the conjunctival flap closure. And also, I'd like to leave the patient with a formed flap and the formed bleb and the conjunctiva away from the sclera.
I have a question for all of you, if you could have something. We always use the mitomycin during surgery. Have you had any experience with using mitomycin subconjunctival injection with the pain or hyaluronic acid preoperatively to prepare the bed for the trap?
Dr. Hossam is routinely doing this. He is the best to answer this question. He routinely injects at the very beginning.
Early before.
I mean, as the first step of the surgery, after doing the conjunctival and opening the tendon capsule and here, I mitomycin in the space. Because the surgery, and it takes time until the section of the conjunctiva, and then I would.
Internet is not
two questions more. We are nearly finishing our time. When you're doing cataract extraction in a glaucomatous patient and cataract extraction in a non-glaucomatous patient, do you have any difference in the follow-up of post-operative treatment? We start with Dr. Ahmed Shama.
حضرتك سامعني يا دكتور حسام؟
أنا سامعك كده.
كويس. أنا ما سمعتش السؤال، أنا آسف. أنا I have difficulties with the internet.
If you're doing cataract surgery in a glaucomatous and in a non-glaucomatous patients, does the post-operative follow-up or management differs, or it is the same?
ههتم أكتر بالميجرمنت of intraocular pressure في حالات الجلوكوما. انما otherwise هيبقى التريتمنت is the same. اذا كان العيان ماشي على الميديكيشن هتاكد ان هو بياخد الميديكيشن بتاعه ومش هبطله الا لما اتاكد ان الانتراوكولار بريشر كويس قوي بعد العمليه ولور ذان اللي انا كنت عارفه قبل العمليه. ساعتها ممكن اجرب ابطل الميديكيشن اللي هو كان ماشي عليه.
Dr. Mohamed, any difference?
You mean that the post-operative regimen for patient with cataract or glaucoma?
I've done cataract extraction for a patient.
Yeah.
Does it differ the post-operative regimen for glaucomatous patients than non-glaucomatous patients? Dr. Ahmed said he must very carefully intraocular pressure for the steroid response that may occur in glaucomatous patients.
Yeah, for sure. If the glaucomatous patient, we have to keep them on the anti-glaucoma medication and watch up for any pressure spikes that could occur early post-operative. And of course, intraoperatively, we have to remove all the viscoelastic in order to avoid these spikes. But for the non-glaucomatous patient, you go for the regimen as usual.
As usual. Dr. Abdelhamid, you'd like to add something?
I think dear professors have mentioned everything.
Okay, I have just two small questions. Just mention the duration. If you're doing, as Ahmed Shama said, sometimes you do trap first. If you do trap first, when you do phaco, after the duration between both surgeries. سامعني يا أحمد؟
لا يا بيه أنا آسف ما سمعتش السؤال.
If you do trabeculectomy first, then you decide to do phaco, what is the time interval between two surgeries?
I'll make sure that the bleb is functioning very well before I go to the second surgery. These cases that I start with the trabeculectomy first are cases with mild cataract and they can wait. Sometimes the cataract progress after the trabeculectomy to the extent that the cataract But in most of the cases, I wait until I'm sure that the bleb is functioning and is very well functioning.
But no specific time interval. Dr. Ahmed, Dr. Mohammed, what do you do in these cases?
Actually, I always go to a combined surgery from the start.
So you don't have the.
So that apply for me. So, but if I have glaucoma surgery earlier than and the patient developed the cataract, which could happen if you are doing glaucoma surgery with a patient with very minimal cataract, which could progress, I should wait for at least 3-4 weeks.
Dr. Abdelhamid, I know you don't do trap, you do non-penetrating. If you do non-penetrating and the patients develop cataract, how long do you stay?
After the non-penetrating, 6 weeks is more than enough, provided the intraocular pressure is okay and cataract is significant.
So do you have any time interval?
6 weeks is okay.
6 weeks is okay. Now I'm going to reverse the question. If you do phaco and then you decide to do trap, how long do you wait? You know, just due to the breakdown of blood aqueous barrier after phaco. So how long do you wait before performing trap?
For me, this is not a nice situation. I don't like this.
Same 6 weeks.
You don't like this scenario?
Why 6 weeks?
To tighten the aqueous barrier.
Okay.
You could wait for the inflammatory process to disappear completely from the patient.
Yes, it's variable from patient to another, with an average 6 weeks.
Okay, we're nearly finished. Any of the panelists would like to add something to this?
I want to just to send ask Karim to share the screen for Dr. Ahmed Shama right now. My screen with a picture for Dr. Ahmed, which is at least 10 years back. Can you share it now, Karim?
Yes, we are seeing it now.
Yeah.
Dr. Osama.
Very nice, Dr. Mohamed.
الغريبه بقى ان انا كنت الوحيد اللي كنت ناسي مين. انا بسال الدكتور المصري مين اللي كان معانا انا ناسي الدكتور احمد شامه فتره طويله قوي. على الرغم ان احنا قعدنا فتره طويله في المانيا مع بعض، يمكن حوالي 4 ايام ولا حاجه كده.
هو انا بس
ماي بليجر والله يا دكتور محمد مهدي.
يا فندم الله يكرمك، تسلم لي، الله يكرمك.
في بس حاجه احب اضيفها في النهايه، هي ان البيشنت اسمه نون ترابابل بيشنت، يعني بيشنت مش هيستفيد من الترابيكيلكتومي ده. مفيش جايد لاينز تقول مين هو البيشنت اللي نون ترابابل بيشنت، لكن في اكسبيرينس وفي ريكومنديشنز بتقول ان البيشنت ده ما ينفعلوش ترابيكيلكتومي، فجوينج فور ترابيكيلكتومي لبيشنتس معينه مش ريكومندد. ودي مسج احنا بنقولها للناس، لان البيشنت بيخسر وقت وبيخسر بروسيدور ملوش اي لازمه. النون ترابابل بيشنتس دول هم اللي كانديديتس ان يتعمل لهم فالف وات ايفر الفالف، وحسب الليفل اوف انترا اوكيولار بريشر النيدد في الشورت تيرم واللونج تيرم بيريود، او يتعمل لهم دايود ليزر سايكل فوتوكواجيليشن لو هم ستيل نون ترابابل. الحاجه الثانيه ان definitely الانجل سيرجري is more promising في الفتره اللي جايه، وانا بشجع البيشنتس او الدكاتره ان هم يبروسيد للانجل سيرجري عشان اتس مور سيف، زي ما كان في شيفت من الاكسترا كابسولر للفيكو ايمالسيفيكيشن. شكرا.
Time for questions دكتور كريم.
دكتور حسام كنت عايز حضرتك سامعني؟
أنا سامعك كويس يا أحمد. أنا سامعك يا أحمد. واضح إن الدكتور أحمد have difficulties in the internet connection.
الإنترنت واضح.
هو كتر خيره الدكتور احمد ما عندوش انترنت في البيت واستخدم الهوت سبوت والحمد لله قدر يكمل معانا البرزنتيشن كلها. I would like it was a pleasure to share this knowledge with all my friends before colleagues. Dr. Mohamed Mahdy from Professor Al-Azhar University, Professor Ahmed Shama, and Professor Abdelhamid. I consider them my young brothers, not colleagues. Thank you all very much for this nice webinar.
شكرا دكتور حسام، شكرا دكتور مهدي، شكرا دكتور شامة، اشوفكم على خير. شكرا RM، شكرا نوفار.
متشكر جدا ان كنت معاكم قوي النهارده.
شرفتنا يا دكتور محمد، دايما
جميعا يعني
شرفتنا
من الجلسه دي.
شكرا.
واحنا شفنا فيديوهات لطيفه وقيمه لحضرتك.
فندم الله يكرمك، الله يكرمك.
خلاص we're going to end this session. Thank you all very much.
شكرا. Thank you. Goodbye.
Bye bye.
السلام عليكم.